Hello, everybody. Welcome to this episode of Infection Control Matters. And I'm on the road this week. It's Martin here, and I'm visiting RAF Brize Norton, where I've been looking at transferring patients with high consequence infectious diseases, but also looking at IPC in an RAF setting. And I'm delighted that Squadron Leader Tez Cooley has taken me around, and Flight Lieutenant Emma Foley, who are both here with me. They've been showing us just what goes on at the RAF. So, Tez, thanks very much, first of all, for asking me to come along, because it's been a fascinating experience.
Delighted to have you here. No, it's really great to be involved with infection control matters. It's done a lot for us as well.
Oh, that's very kind of you. So, Tez, you've taken and shown us the unit, but could you describe the process of what happens if you're going to be bringing somebody back from probably another country with a suspected or actual high consequence infectious disease? What's the process?
Yeah, sure. So here in the building at RAF Brize Norton, we will get a phone call, which comes all the way down from the government, so ministerial level, and they will tell us we've got a patient. And that patient could be a military personnel, Army, Navy, Air Force, or it could be civilian. From getting that phone call, we've got 24 hours to get airborne. So we'll get our teams, we'll call them in, and they're not based here. They could be based all over the country. So we will get those personnel to RAF Brize Norton, and we'll load all of our kit on. That kit is all the normal stuff you'd expect of healthcare. So Tyvek suits, gloves, alcohol gel, Clinell wipes, etc. But we've also got what's called an Air Transportable Isolator, a large plastic bubble with some filters, and it's basically a hospital bed on wheels. We get that all loaded on the aircraft, and then we'll get out. Our record so far is to be airborne in 6 hours, but we normally work to about 24 hours. We'll fly straight out to where the patient is. Like you say, these diseases that we would normally deal with, the viral hemorrhagic fevers, we're looking sort of across the sort of Central and West Africa region generally, but we can get anywhere on Earth within about 24 hours again. And then we'll go and collect the patient. Now, our goal is to isolate early. So we will send a team forward and get the patient, and they'll be in the full head-to-foot PPE. We'll fit to fly the patient. So obviously, when you're going a plane, that affects your physiology quite a lot. So we want to make sure that us putting the patient in a plane isn't going to do them any harm.
Could you describe how going in a plane affects your physiology?
Yes.
I wasn't particularly aware of that until you went through.
This is one of the things we train all RAF medical professionals in, aviation medicine. So, for example, as the pressure decreases, as the plane rises up into the atmosphere, the gas will expand inside you. So if you've got gas behind your eye and your stomach from surgery or anything like that, as like surgeons like to do when they inflate people up with CO2, that will expand to about 3 times its size.
Wow.
Which could obviously cause huge problems. Common ones, obviously, your ears popping. If your ears can't pop, that will cause a lot of pain and eventually rupture. There's lots of other things. So your blood oxygen saturations will start to decrease. So if your breathing's already compromised, then that could really escalate that problem. There's loads of little things like this which we'll be considering to make sure that a patient is safe for the whole journey.
Okay.
So yeah, once we've made sure the patient's fit to fly, we'll make sure they haven't got anything we don't like. So no knives, no sharp, pointy things. I'm afraid we're taking that all off you.
So they would come in their normal clothing, but you're not going to...
Absolutely.
Okay.
Yeah. So we will just let them fly in whatever they're wearing with no special requirements for that, but we do check what they've got with them. So a book, a Kindle, that's absolutely fine. Sharp knife, no, I'm taking that off you. We'll get them loaded onto the stretcher, and then we'll come back to the aircraft where our isolator is waiting, and the other half of our team has got this all set up for us. And we've got a very defined procedure, and this is all managed by an IPC nurse, where we very carefully transfer the patient across the clean dirty line into the isolator, which is on the clean side, and then get everyone who's been on the dirty side away from the isolator.
So that's the end of their role, isn't it?
Yeah, for the moment, that's the end of their role. They go off to decontamination. And then we'll have another 2 people who then step across the line into the dirty zone, so they've never been anywhere near the patient, and then they seal the isolator, and clean it down and make sure it's all clean. And then they start getting it loaded onto the aircraft. We've got our environmental health technicians who we work with, and they help us get decontaminated and get through that decontamination lane. So we're back into our normal uniform or scrubs and get back on the aircraft. Again, the IPC nurse will be overseeing all of that, and they will be the very last person through the decontamination lane, making sure that everyone is adhering to those standards so we don't get a contamination event.
Okay, just quickly, before the patient gets in, often you said they're mobile and able to cooperate. So Will you ask them to go to the loo or give them something to eat or have a wash before they get in it? Because once they're in it, there's not a lot they can do, is there?
It's limited, so we will ask the doctor before we get there, whoever's looking after them, to prep the patient as much. So pain relief, anti-sickness, all that sort of stuff. And please do go to the toilet before you fly.
Yeah.
But we do have bedpan inside.
Okay.
We can facilitate going to toilet. It's not the most dignified, but we'll do what we can for you.
Yeah.
We will put snacks inside the isolator for you as well, because it's going to be about a 12-hour flight.
I was going to say, this is not a short flight, is it?
No, it's definitely. So there's international regulations actually about flying over other countries' airspace with a dangerous pathogen on board. So generally what we do is we fly around international airspace. So if you can imagine, if we were coming back from somewhere in Africa, we would have to go all the way around the outside of Europe to get back to the United Kingdom to get back that patient back to the NHS.
Right, okay. I mean, presumably some countries are comfortable and others definitely,
as a rule,
you have to do an emergency landing. I mean, some they may not even have an airport that would take your plane.
Yeah, so you're exactly right. The aircraft is a big aircraft that we have to use. So we need a big international airport that can take an aircraft of that weight. Obviously, human safety comes first. If we had an aircraft emergency, we would divert immediately into the country whose coastline we're following and land the plane safely. But for ease of overflight, we normally go around the outside on the way back.
Yeah. Now, you don't do this very often. So, Emma, how often do you do training on this? Because there's going to be a lot of skill involved in doing this and a lot of competence, and a lot of people must have confidence in their methods. So how is the training carried out?
Yeah, so you're right. Because of the infrequency of our missions, it's really important that our trainees are educated appropriately on using the ATI and its associated equipment. Obviously, as SMEs, we have daily hands-on experience.
Going to have to go acronym here. SME?
Subject matter expert.
Okay.
So, yes, as subject matter experts, we have hands-on experience with the ATI day-to-day. But for our trainees, obviously, that's not the case. What we do is we run a training course that's about 3 days long, where trainees come and they are familiarised with the ATI. They learn the appropriate skills and drills on how to do things like bus in equipment or supplies for the patient. Equally, we teach them how to get things out of the ATI, how to do things like a glove change, very simple manoeuvres on the ATI, but that actually in a serious scenario could actually really help keep the patient and themselves safe.
Yeah.
We also, as part of that training piece, we take them on an exercise. If we can, we like to fly with them because obviously the immersion experience makes it more realistic. So but if we can't, what we do is we put them onto the back of a rear crew trainer. So a mock-up of an aircraft that we would use in real life size. And we would take them on an exercise that lasts about half a day where we condense that end-to-end process of a patient transfer into that time frame. And there we have the patient in the ATI. We run the scenarios with the students so that they can become more familiar and confident in those processes and in themselves as clinicians.
Yeah. Presumably these are volunteers, people who actively want to do this.
They absolutely are. So these can be clinicians or non-clinicians through a variety of specialisms. So we have nurses and medics. We have doctors. We also have the environmental health technicians that Tez has already mentioned, and the electrical engineers who work for the Royal Air Force, who take care of all of our electrical medical equipment and the batteries on the ATI itself. So they all come through the course. They are volunteers. The prerequisite for them to do the course is that they have to be trained in aeromedical evacuation on the ground phase of the course. Once they have done that, they are free then to volunteer to come and work with us, do the course and become qualified. Once they're qualified, that stands for 3 years. That's not to say that they are not welcome to come back to us. Whenever we run a course, we always invite people back to have refreshers so they can come and spend half a day with us doing those skills again. So it's validation for them that they are still confident in applying those skills should they be called on at short notice. What else we do once they have done that 3-year qualification, they're then invited to come back again and refresh the entire course again. But of course, there's no obligation for them to do that. They could have then been pulled in a different direction in their career path at that point, I suppose.
Okay. So you got the patient on board the aircraft, Tez. What's it like in flight?
On a live mission, hopefully really boring. That's what we always want. So what we would do is we would put a big yellow and black line down the middle of the aircraft. And then we separate down to clean, dirty, and the isolator and the patient is on the dirty side, even though it's really not dirty.
Yeah.
It's just managing that risk as low as possible, and all our equipment's on that side. Generally, everyone will take a break, and then we'll just have 2 clinicians inside the dirty zone with the patient, keeping an eye on them, doing routine observations, delivering any medications, helping out with food, chatting to the patient, just making sure they're okay, those little things, because actually it's extremely stressful time for the patient and they need a bit of interaction. Everyone else on the clean side can take a break, they can have a nap, eat some food, etc. Because obviously we've had an 8-hour flight out there, probably a couple of hours on the ground. We've now got a 12-hour flight back, so we need to cycle to keep people fresh.
Yeah, sure.
We're also talking to the air crew. So I've got I've got more than one pilot. I've got several pilots flying the plane for me. I've got a load master dealing with the back of the plane. They need to know what's going on. They want to know are they safe? And invariably, they always think the worst. They're convinced, but the ATI is going to explode and the patient's going to escape or something. So we just have to say, actually, this is a very, very safe. It's tried and tested. We've done it lots of times. It's fine. And it's that reassurance to the crew. Also, mission updates. So we've got our team back here who coordinate the whole move for us. They talk to all the partners we work with, like Thames Valley Police, the NHS, the ambulance service. All of those people were involved, including public health, UKHSA, all those things. So we'll be coordinating with them saying, yes, we've got the patient. Right, we're taxiing now. Okay, we've taken off. Right, we've come past Spain. We'll be landing in however many hours and all that sort of stuff. Although we want a boring flight, we train for the worst. So as Emma said, on the training exercise, it's always the worst day ever for the students. Everything goes wrong. So right from the patient finds a knife, we always manage to hide one somewhere. So they have to get that out. The patient then demands that they need an apple. So we have to, they have to get an apple inside.
How do you find one of those at 35,000 feet as a matter of
there's always an apple. There's always an apple in a snack box. We have catering. It's good. The patient will start bleeding. And then they'll get blood all over one of the gloves. So then they'll have to stop the bleeding, do a glove change, and then decide if they want a new cannula and stuff like that. And then we ramp it right up. The patient will have a full seizure. Yeah. The critical care qualified personnel we bring with us will have to come in and start managing, what is essentially a patient with a potentially viral hemorrhagic fever now going into a full seizure. And we can do that all in the air.
Right.
So we train for the worst and hope for the best.
Yeah.
And generally, every single flight we've done since sort of 1980s, all the flights have been incredibly boring, which is how we like it.
Yeah, exactly how you like it. So you're coming back to the UK. You go to one of 2 airports, is that right? And then what's the process when you switch back?
Yeah, exactly that. Again, the guys upstairs, they do all the coordination for us, and they will speak to the NHS HSID network. And they will tell us where they want the patient. And there's two options on that. They've got high-level isolation unit beds at Newcastle and at the Royal Free in London. Historically, we've always gone to the Royal Free, but we do as we're told, as we're very good at doing in the military.
Yes.
In that case, we'll land at RAF Norfolk. So we work with Thames Valley Police. They close the roads for us. The ambulance service will be waiting with one of their HGID ambulances. And we've got our own HGID ambulance. Again, at no point does the patient ever come out of the isolator. So the isolator is just loaded onto the back of our ambulance. And we, again, travel in no PPE, just gloves. So it's nice for us. And we'll go on blue lights straight through London. I'm told by the drivers who've done it, they can do it in about 20 minutes.
Wow.
Norfolk to the Royal Free. Once we get there, the matron from the Royal Free will come out with their team. We exercise with them regularly. So once every year or so, we'll go down and do a big exercise where we take a patient to the Royal Free and we test their systems as well. And again, we do as we're told. We'll rock up there, offload the ATI. The hospital will be shut down, one wing of it. And then they will lead us through. All our clinical waste comes with us, patient, and we've got a transfer box with all emergency equipment, and we'll just go straight through the hospital up to the isolation unit. They have a system called Trexler, which is a high-level isolation bed inside a negative pressure room, and our isolator is directly compatible with that. So under their guidance, we'll connect the 2 systems, which leaves a little corridor, maybe about half a foot long. Now, most of these patients, we get them so fast, they're actually fitting well. The disease hasn't got to the point where it's making they might have a headache, they might have a bit of a fever, but actually they're fairly fit and well. We'll ask them very nicely to crawl down the tunnel into the Trexler bed, and then we'll use a heat gun to seal off the connecting tube, and that gets dipped in chlorine and all the rest and got rid of. If they're not fitting well, then it's a case of 6 of the nurses from the Royal Free will get their hands into the Trexler bed. 6 of our nurses and medics will get their hands into the isolator. and then we'll just pick the patient up and post them through.
Yeah.
After that, we'll do a clinical handover, so clinician to clinician directly to the Royal Free team, and they will take over their specialist job, which is the treatment of that patient, that's what we need them to do. We do the transport for the HSID service, they do the treatment, and they're really good at it, very experienced. They also offer us a service where they sort our isolator out for us. So obviously we've got this nice dirty isolator. They've got all the equipment. They've got a giant autoclave. So they've got the clinical waste contracts, everything in place. So we can collapse all the disposable bits of the isolator. That gets autoclaved and burnt. And then all the reusable bits, all the metal frame and stuff, that will get thoroughly cleaned with HPV gas, lots of chlorine wipes and things like that. And then we'll pick it up and then we'll recycle, buy a load of new consumable bits, and we're ready to go probably within about another 48 hours after that.
So the tent, everything just collapses in on itself.
Yeah, absolutely.
Do you HPV gas the frame there and then, or do you bring that away and do that because you then got to transport something?
So no, and again, actually there's law surrounding the transport of contaminated waste like that.
Right.
So we've got permission to transport it from where we land to the hospital, but then it has to be done there.
Okay.
And so, it basically gets locked in a room. The HPV gets turned on. We turn the isolator on so it sucks through the gas and keeps circulating through the isolator to clean all the filters, to clean the inside. So, you've got 3 stages of cleaning. It's very safe.
Okay. I'm wondering about the inside of the plane. Do people get concerned about that? Do you do anything with that at all? Because the patient's being, as you say, sealed inside a tent. So there really shouldn't be any contamination, but human nature would be people would be nervous about that area because it's classed as a dirty area. What do you do with that?
So absolutely, yeah. And you're right. People do get concerned about it. Now, if we're removing a HSID patient and they're inside the isolator, the risk is incredibly small. It's virtually zero. But we don't just move HSID patients. We move all kinds of infectious patients. And there is a chance we could have a spill, we could have a vomit, we could have a diarrhea, any of those sort of things. And we have to comply with all of the air regulations as well. Now, aircraft are very, very precious, they're expensive, and they're very delicate. So you can't use, for example, chlorine-based products on what we would call the airframe, the structure of the aircraft. So I could wipe my medical monitors and stuff like that with your normal chlorine wipes, fine. I cannot touch the aircraft because it will degrade the metal. So we have material scientists in the armed forces who work this all out for us and tell us exactly what chemicals we can and can't use to clean on the aircraft. And even when we do, we have to then inform the air load master and the pilot, who will then take it back to engineering to assess the aircraft if they need to replace any parts or do any swaps like that.
Okay. I mean, how often then do you do transfers then of infected patients? Would that still come under your wing? You'd supervise transfer of infected patients, or would that be just a medical evacuation and then you might give a bit of advice in particular rather than leading on it as you do with a high consequence infectious disease?
So because we are such a small team, so a tactical medical wing, Bryce Norton, we are a team of maximum 4 people in the wing itself. So we don't have the luxury of being able to send people out on Aeromed missions as much as we would like to. But what we do is we provide a reach back and an advice giving service to people both here at RAF Bryce Norton, but also all over the country and globally if required, so that if there is a patient who may present an infection control risk because they have a suspected or confirmed diagnosis, that we can provide some advice pertaining to aviation medicine and care in the air of that patient and how we would best manage them. So we don't necessarily escort those patients as much as we would like to.
Yeah.
There are occasions, I think, where we can and we have, but that is obviously a workforce availability issue for us.
4 of you.
Yeah, we are a very, very small team.
Yeah. Okay. I mean, in the event of a major escalation, would they look to increase the team, or would it just be, well, we'll do what we can with what we have? Because I understand that IPC is absolutely the fore of transferring a high consequence infection, but when it comes to a normal theatre scenario, IPC drops a bit down the priority list, doesn't it? Because there are other things that have to happen, and you're really sometimes damage limitation rather than getting in first with the preventative. That's tricky.
Absolutely right. So it all depends on the circumstance around the mission, what type of mission that is, and the environment that patient is in. So if you're operating in a more austere environment and you need to get the patient out of there quickly for their safety and for your safety, you're right, it is a lot of damage control that takes place. And if there are infection control matters that need to be dealt with further down the line, then we would obviously step in and assist and deal with that. But the patient safety has to be at the forefront of what we do, no matter what the scenario is that we're faced with. We encourage our clinicians throughout the RAF to deliver the best possible standard of patient care and the best possible infection control care that they possibly can with the instruments and the consumables that they have at their availability. Naturally, if you've got clinicians who are working in a more tented environment versus your lovely secondary healthcare environment hospitals, what they have at their disposal is hugely different.
Yeah.
So it's just a case of a lot of risk assessment, a lot of sensible decision making, and a lot of us in the IPC team putting our heads together and deciding what the best possible solution to their issue is in that instance.
It's being pragmatic, isn't it?
Absolutely
That would be ideal. That's not possible. Therefore, what are the critical control points that we can put something in place that would mitigate them?
You're absolutely right,
Yeah. I mean, do you find that frustrating sometimes to say, I would really love to do that, but I can't?
Yeah, I think naturally that comes with the territory of being an infection control nurse. And I think as clinicians in that environment and that sphere, we would walk into a secondary healthcare environment or a primary healthcare environment, and we will eyeball stuff, and there will always be things that we don't quite like.
Yeah.
So when you are faced with a scenario where it is almost the polar opposite of what you would like, it encourages a little bit more of adventurous thinking. We have to get quite creative with how we deal with certain things, but actually it can serve us quite well because some of that is then transferable into those primary and secondary healthcare environments where, I think a lot of the practices that are in the modern hospital like environments that we work in sometimes, innovation sometimes is lacking because you tend to do things that way because it's always been done that way.
Yeah.
Whereas because we tend to be more innovative in the military and in the Royal Air Force, we then use some of the things that we learn and the skills that we acquire, and we're able to transfer those and share them with NHS colleagues that we get to work with.
Okay. Could you give me an example of something that you've thought, actually, we've always been doing that way in the NHS, but there's a quicker and shorter way or a better way or a more creative way?
So I think a really good example would be one we've brought in recently, which is on aircraft and certain deployed locations where the host nation's water system maybe just isn't up to the standard we would require. Hand washing can be really difficult. So we've trialed a whole load of products, basically hand wipes, and how effective they were at actually getting the pathogens off the hands and making hands safe again. And we've now pretty much brought a solution into service. And we've got them in a nice little size which suits our Aeromed nurses really well. So they can just tuck them in their pocket. We've got a patient pack, so we can just, as soon as the patient comes on, here you go, here's your hand wipes. And they're just almost as good as washing your hands. Yeah. Especially when there's no water available. Yeah. It's better than alcohol gel.
Yeah. Yeah. I mean, the physical removal is good.
Yeah.
As opposed to alcohol. Okay. Well, thanks very much. An absolutely fascinating visit. Standing in front of inside a mock-up aircraft, you get some idea of the space you've got to work with. And, I asked you, Emma, could you get one of your units in the Chinook? But it was very obvious that wasn't going to be possible. So fascinating. But I really appreciate the chance to come and visit you and have a look at it. It's been fascinating. Thank you so much.
Oh, thank you. No, it's been great to have you here.